Okay, so picking up where we left off last time, 18.8, let's talk a little bit about arteriosclerosis. I'm sure you've heard of this before. In this case, we have thickening and toughening of the arterial walls, and the related complications do account for about half of the U.S. deaths. That's really significant. Coronary artery disease, or CAD, is basically arteriosclerosis of the coronary vessels. There is also arteriosclerosis of the brain arteries that leads to stroke. But that is significant. Complications accounting for half of the U.S. deaths. And you know, this is something that we can actually do something about. It's related to some of the bad habits that we have. Also, atherosclerosis, formation of lipid deposits in arterial tunica media, which causes damage to the endothelium. And this really is the most common form of arteriosclerosis, associated with elevated blood cholesterol. You get a fatty tissue mass called plaque in the vessel, and it restricts blood flow. Now, what happens in this case, as this fatty tissue builds up the plaque, it actually starts building up calcium deposits also. And there's actually a chemical called EDTA that there's been a lot of experimentation on. EDTA chelates calcium. That means it binds to it. And if EDTA is brought into your body sees EDTA as foreign, and it pretty much just gets rid of it. So the thought is if EDTA goes in and binds to the calcium, it'll grab it, pull it out, and then your body will just simply get rid of it. So it's got a lot of potential. Now, a lot of risk factors for arteriosclerosis includes age. So the older you are, the more chances you might have. Also, males are more likely to have arteriosclerosis. High blood cholesterol levels, high blood pressure, and cigarette smoking. Also, a major study came out yesterday or the day before. There's been several studies, but a big one came out yesterday now linking vaping now to a lot of the same problems that people have with regular smoking. So I think that there's been a lot of talk that might happen. There's a lot of hypotheses put forward that there are some similar chemicals that might lead to some of the same problems. I'm curious as to see what other studies find. Atherosclerosis treatment, you can replace damaged segments of the vessel. You can also do compression of the plaque using balloon angioplasty, quite commonly used. In this case, you insert a catheter past the blockage. The balloon's inflated. It presses the plaque against the wall. It opens the vessel. This is mostly effective for the smaller, softer plaques. Also has a very low surgical mortality rate, about 1%, so that's good. High success rate, greater than 90%. And it can be outpatient, so that's a bonus. In coronary artery disease, we have areas of partial or complete blockage of the coronary circulation. So this, again, is the blood supply to the tissues of the heart. So when we have reduced blood flow to the area, we call it a coronary ischemia. And that's usually from atherosclerosis in a coronary artery or an associated blood clot that we call thrombus. We can use digital subtraction angiography to see this. And treatment can include a wire mesh tube we call a stit. I'm sure you've heard of stits before. They're used quite often. It holds the vessel open. So we have two angiographs here. On the left, you have a normal heart. So you see that the branches of left and right coronary arteries are clearly visible. On the right, you have a person with advanced CAD. Blood flow to the ventricular myocardium is severely restricted in this case. Okay, in this graphic, you can see where they have inserted a stent to enlarge that vessel. Okay, so now we're going to move into talking more about the cardiac cycle, like was in that part 2 video from Crash Course Anatomy and Physiology. So we're going to talk about cardiac systole and diastole and other events of the cardiac cycle and the heart sounds. We'll talk about how action potentials propagate through the heart, the role of calcium ions. We'll talk about the conducting system, the electrical events shown on an electrocardiogram, factors affecting heart rate, variables that influence stroke volume, and we'll talk about how stroke volume and cardiac output are coordinated. And in your next lab, we'll be doing more heart physiology where we deal with some of this. So the cardiac cycle is the period between the start of one heartbeat and the next. When we talk about heart rate, we're talking about the number of beats per minute. So two atria contract first. That fills your ventricles. Although again, a lot of the filling of the ventricles is simply by gravity. The two ventricles then contract to pump blood into the pulmonary and systemic circuits upward. So in this case, the systole of the ventricles is a much more intense contraction because they are contracting against a much higher pressure. Okay, so the two phases, contraction, systole, blood leaves the chamber, relaxation is diastole. That's when the chamber refills. In this case, we're talking about the ventricles. So here's the sequence of contractions. The atria contract together first. That's atrial systole. It pushes blood into the ventricles. And at that time, the ventricles are relaxed, so we have ventricular diastole, so they're filling. Then the ventricles contract together. That is ventricular systole. We push blood into the pulmonary and systemic circuits. The atria now are relaxed, so that's diastole of the atria and filling. So your typical cardiac cycle lasts about 800 milliseconds. That's a very short time. Okay, here's the entire cycle. And notice there's some overlap of atrial systole, atrial diastole, and ventricular systole and ventricular diastole. Okay, so let's look more at the cardiac cycle. So the cardiac cycle begins. All four chambers are relaxed at this point. So it's total diastole. The ventricles are passively refilling at this point. Then we have atrial systole. The atria contract. That finishes the filling of the ventricles. Number 3, we have atrial diastole now, so the relaxation of the atria. This will continue until the start of the next cardiac cycle, on through ventricular systole. And then we have the first phase of ventricular systole. The contraction of the ventricles push the AV valves closed, but there's not enough pressure yet to open the semilunar valves, not at the first phase, okay? So at this point we say we have isovolumetric contraction because there's no real volume change. There's enough pressure at this point to close the atrioventricular valves, but not enough to open up the semilunar valves to the pulmonary or the aortic. Okay, second phase of ventricular systole is here at number 5. Now we have increasing pressure that now opens the semilunar valves. So now blood is going to leave the ventricles. It's going to go into the pulmonary trunk and into the aorta at the same time. So this is ventricular ejection. Now we're going to move into ventricular diastole, the early phase. The ventricles relax, their pressure drops. Now blood in the aorta and the pulmonary trunk starts backflowing. This closes the semilunar valves, so we don't have mixing of the oxygenated and deoxygenated blood. And then we have isovolumetric relaxation. All the valves are closed. There's no volume change. Blood is passively filling the atria now. And then the late ventricular diastole, all the chambers are relaxed, all the valves are open. The ventricles fill passively to about 70%. And we start all over again. Let's see if I can get the SmartArt video to show here. Let's see. There we go.
Welcome to another Anatomy and Physiology Smart Art video, where we guide you through an important piece of art. After watching this video, you should be able to explain the events of the cardiac cycle. Diagram here is a single cardiac cycle, which lasts about 800 milliseconds, or 8/10 of a second. Let's begin here at the red arrow labeled start. In this first image of the heart, all four heart chambers are relaxed, therefore in diastole, and partially filled with blood. Atrial systole, also known as contraction, begins and completes ventricular filling. Notice, the green arrows show the atria contract, and the black arrows indicate blood flowing into the ventricles. Atrial diastole follows and continues until the next cardiac cycle begins. Ventricular systole now begins, and is a process divided into two phases. The first phase, shown in this figure, is isovolumetric contraction. It is called isovolumetric because the volume of blood within the ventricles does not change. During this initial phase, ventricular contraction closes the atrioventricular or AV valves. The second phase is ventricular ejection, when the ventricular pressure finally exceeds the pressure in the arteries, and that pressure increase opens both the aortic and pulmonary semilunar valves. Blood now exits the ventricles and is forced into the aorta and pulmonary trunk. Here, in early ventricular diastole, blood flows backward towards the ventricles as ventricular pressure rapidly drops. This backflow of blood against the semilunar valves causes them to close. At this time, blood is also flowing into the relaxed atria. Notice here, the AV valves are still closed. This phase is called isovolumetric relaxation. Finally, in late ventricular diastole, all chambers are relaxed, filling passively to about 70% of their capacity. To summarize, a single cardiac cycle includes atrial systole, when both atria contract at the same time to complete ventricular filling, followed by ventricular systole. Isovolumetric contraction is the first phase of ventricular systole and causes the AV valves to close, while the second phase is ventricular ejection, which opens the semilunar valves as blood is forced into the arteries. As blood pressure rapidly drops in ventricular diastole, the semilunar valves close and the ventricles begin to fill again as all four chambers of the heart rest and passively fill prior to the next cardiac cycle. So what? Why is it important to understand the events of a normal cardiac cycle? Well, this is crucial to understanding many serious heart conditions. For example, suppose a patient has a myocardial infarction, also known as a heart attack, that has seriously weakened the left ventricle. Left ventricular ejection will decrease, blood flow will back up between the left and right sides of the heart, resulting in congestion in the lungs. The resulting respiratory complications can be life-threatening. And to understand the many congenital defects of the heart, it's important to grasp the normal cardiac cycle, as these cardiac abnormalities interfere with normal blood flow and valve function.
Okay, so that's another video you might want to go back and watch again. Okay, let's talk about the pressure gradients that are occurring throughout this. So we have an increase in pressure with the opening of the aortic valve. We have a drop in pressure with the closing of the aortic valve. And that's followed by a short pressure rise as the aortic elastic walls recoil. So do keep in mind that there is some natural pressure created simply by recoil. This produces a valley in the pressure tracing that we call a dichrotic notch, what we call double beating. So pressure changes in the aortic and the left chamber during the cardiac cycle are seen here. It shows you the dichrotic notch. This occurs in the elastic walls of the aorta as it expands to receive the incoming blood. And then after that, you see a peak that shows the effect of the elastic recoil. And we'll be going over this chart a little bit more. Let's talk about the heart sounds. You've probably heard us refer to these as love-dove. The first sound, S1, love, is when the AV valves close. That marks the start of ventricular contraction. Because remember, it's the pressure that first builds up in the ventricles that close the AV valves. The S2 or duff sound is when the semilunar valves close. There are actually two other slide sounds, very faint. You're normally not going to hear these unless you have a particularly good stethoscope. And this probably going to have to be some kind of electronic version. S3 is the blood flowing into the ventricles. S4 is the atrial contraction. Okay, so the first sound, AV valves close. The second sound, the semilunar valves close. Let's talk about a comparison of skeletal muscle and cardiac muscle, which we've talked about before, but it'll make a little more sense now in terms of how the heart beats. So skeletal muscle, we have a brief action potential is a short twitch contraction that begins, and then the contraction ends when the sarcoplasmic reticulum reclaims calcium. We have a short refractory period that ends before the peak tension develops and the twitches consummate, and you can get tetanus. In the cardiac muscle, we have a long action potential. Calcium enters the cells over a prolonged period. We have a long contraction. Refractory period continues into relaxation, and there's no tetanic contractions. Just imagine what would happen if you had tetanus to occur in the heart. One complete contraction, that would be it. Okay, so this shows the action potential and the contraction that occurs right after that first action potential when it comes to skeletal muscle. Here's the cardiac muscle. As you can see, you get the action potential, and it's a little more prolonged, and the contraction is also prolonged. So we have three stages of the cardiac muscle action potential. So we have a rapid depolarization. Remember, depolarization from 168 means we have this sudden sodium coming in and you get less negative. Because usually we have like something around a negative 55 inside. We go away from that. And you hit that trigger point or that threshold, and then you have that real action potential occurring. So you have that rapid depolarization. Let's see, they show it started at -90, then you hit the threshold, and then you go up to +30. Then you hit a plateau, and then you get repolarization where you go back to negative. Remember, part of that is where you start sending potassium out of the muscle cell, but eventually the sodium-potassium pump kicks back in, and you reestablish the sodium and potassium balance. So rapid depolarization in this case in the cardiac muscle is similar to that in skeletal muscle. At threshold, the voltage-gated fast sodium channels open. You have this massive influx of sodium. So you go away from this -70. The channels open quickly and very briefly. Then you hit a plateau. The membrane potential stays near 0 millivolts because of two opposing factors. You have fast sodium channels that close as your potential nears the +30 millivolts. The cell actively pumps sodium out. You have voltage-gated slow calcium channels that open, and you have a calcium influx. So this is a bit different than in the skeletal muscle. The calcium becomes more important here. Then you have repolarization. Slow calcium channels close, slow potassium channels open. Potassium rushes out of the cells, and therefore you go more negative because potassium is positive. And you restore the resting potential back to that negative 90. Okay, another term you're going to use pretty regularly, cardiac output. It's the amount of blood that's pumped from the left ventricle each minute. This is determined by the heart rate and the stroke volume. And within each person, it is precisely adjusted to meet the needs of the particular tissues. Okay, so that's the equation. Cardiac output is heart rate times the stroke volume. And heart rate is simply the number of contractions per minute or beats per minute. When we use the term beats, we're talking about contractions. Stroke volume is the volume of blood pumped out of the ventricle per contraction. So here's an example. 75 beats per minute times 80 milliliters per beat gives you 6,000 milliliters per minute. And of course, in your system, you can, not consciously, but your body can adjust either your heart rate or your stroke volume as needed. Okay, autorhythmicity, this is the ability of your cardiac muscle to contract at its own pace, independent of your neural and hormonal stimulation. This is a good thing in your bodies. You do have a conducting system, which is a network of the specialized cardiac muscle cells. So you have a pacemaker, you have conducting cells. They're going to initiate and distribute the stimulus. And the components of this system include the sinoatrial node, or the SA node, internodal pathways, the atrioventricular node, or AV node, the AV bundle and bundle branches, and the Purkinje fibers. And we're going to talk about all of those. Okay, so first, with the conducting system, the sinoatrial node. This is the pacemaker. Each heartbeat begins with the action potential that's generated there. It's in the posterior wall of the right atrium, as you see in this picture, near the superior vena cava. That's where the impulses are first initiated, and then they spread through the adjacent cells, about 60 to 100 beats per minute. And then we have internodal pathways. These are formed by the conducting cells. They distribute the signal through both of the atria. So the internodal pathways are shown here at number 2. At number 3, we have the atrioventricular node. It's at the junction between the atria and the ventricles, and it relays the signals from the atria to the ventricles, as you might guess. It also has pacemaker cells that can take over pacing if the SA node fails. So if this one doesn't work, this one will take over. But the AV node pacing is slower. It's 40 to 60 beats per minute. But it's a backup. Okay, number 4, we have an AV bundle. These are conducting cells that transmit the signal from the AV node down through the interventricular septum. And usually it's the only electrical connection that's between the atria and the ventricles. And then at number 5, we have bundled branches, right and left branches. The left bundle branches are larger. The conducting cells transmit the signal to the apex of the heart. Then they spread out in the ventricle walls. So if you follow from 1 through 5, you see there's a real pattern to it. And the purpose in that pattern is so that the muscles contract in a pattern. And the Purkinje fibers, these radiate upward through the ventricular walls. They have large diameter conducting cells. They propagate the action potentials as fast as your myelinated neurons, very fast. And they're going to stimulate the ventricular myocardium and trigger the contraction of the ventricles. Now, let's look at the conducting system, say in an ECG tracing. So, number one, the action potential is generated at the SA node. So we have atrial activation beginning. So in our ECG tracing, we see this first line. And then at number 2, the stimulus is going to spread across the atrial surface within the internodal pathway to the AV node. It's about 50 milliseconds. You get your first P wave. That's when atria depolarize. At number 3, 100 millisecond delay occurs at the AV node, and this is when the atrial contraction occurs. This is when you get what we call the P to R interval, this line right after the P. Again, it's conduction through the AV node and AV bundle. Number 4, the impulse travels along the interventricular septum within the AV bundle, and the bundle branches to the Purkinje fibers by the moderator band to the papillary muscles of the right ventricle. And now the ventricular contraction begins. This is the Q wave. See that sudden dip? This is the beginning of ventricular depolarization. And then at number 5, the impulse is distributed by the Purkinje fibers throughout the ventricular myocardium, and the ventricular contraction completes. And that's when you get this large QRS complex. This is the completion of ventricular depolarization. So all this time when you have been in a clinical situation and you've seen those ECGs, you probably had no idea what that meant, although you knew it had something to do with the heart. But each of those parts means something, and we can tell based off of whether each of those parts of that tracing are doing what they're supposed to, if something specifically is going on and where the problem is.
Welcome to another Anatomy Physiology Smart Art video, where we guide you through an important piece of art. After watching this video, you should be able to describe the conducting system of the heart and the electrical events shown on an electrocardiogram. Let's begin by looking at this image showing the heart, its conducting system, a network of pacemaker cells and conducting cells. An electrocardiogram, or ECG, also known as an EKG, measures the electrical activity of the conducting system. Let's move to step 1. Each heartbeat begins with an action potential generated by the sinoatrial or SA node. The SA node is a cluster of pacemaker cells embedded in the posterior wall of the right atrium. Step 2, the action potential travels along the conducting cells of the internodal pathways and spreads across both atria. We see this depolarization of the atria as the P wave on an ECG. In step 3, the action potential continues to the pacemaker cells, the atrioventricular or AV node, located at the junction between the atria and the ventricle. It can be seen as the PR segment. At this time, atrial contraction actually occurs. Now let's move to step 4. As atrial contraction completes, the impulse moves along the interventricular septum, conducting cells of the AV bundle, the right and left bundle branches to the Purkinje fibers, as well as the moderator band and the papillary muscles of the right ventricle. In step 5, the Purkinje fibers distribute the impulse throughout the ventricular myocardium, causing the ventricles to contract. We can see this ventricular depolarization on an ECG as the QRS complex. Ventricular contraction, however, begins shortly after the peak of the R wave. The atria are repolarizing at this time, but the repolarization is masked by the QRS complex. To summarize, the heart's conducting system consists of pacemaker cells of the SA and the AV nodes, and conducting cells of the internodal pathways, AV bundle branches, and Purkinje fibers. The electrical events of the conducting system can be seen on an electrocardiogram, with the P wave representing atrial depolarization and the QRS corresponding to ventricular depolarization. Remember that the atria actually contract during the PR segment. The ventricles contract shortly after the R wave peak, and the QRS complex masks atrial repolarization. Notice in this ECG tracing the T wave, which represents ventricular repolarization. So what? Why is it important to understand the heart's conducting system and the electrocardiogram? Well, this knowledge is crucial to detecting and diagnosing cardiac arrhythmias, abnormal patterns of the heart's electrical activity. Cardiac arrhythmias can be caused by drugs and hormones, a heart attack, or for unknown reasons, and can range from temporary and relatively mild conditions, such as premature contractions of the atria or ventricle, to life-threatening, as in ventricular fibrillation, when the ventricles quiver and are unable to inject blood. Many other cardiac arrhythmias and treatments range from medications to the surgical implantation of an artificial pacemaker to regulate heart rate.
So we're just talking about the ECG or EKG. That's reported of the electrical activity from the body surface. And it assesses performance of the nodal, conducting, and the contractile components. If part of the heart is damaged by heart attack, we can see abnormal ECG patterns as he showed in that video. And the appearance is going to vary with the placement and number of the electrode leads. So that's very important where those are placed. So again, the P wave is basically showing us atrial depolarization. Atria begin contracting about 25 milliseconds after the P wave starts. The QRS complex is ventricular depolarization. We have a larger wave because of the larger ventricle muscle mass that is there. The ventricles begin contracting shortly after the R wave peak. And as he said in the video, atrial repolarization also occurs now, but you don't see it on here because it's masked by that large QRS complex. The T wave, that is ventricular repolarization. The P to R interval, this has appeared from the start of the atrial depolarization to the start of ventricular depolarization. Greater than 200 milliseconds could mean that you have damage to your conducting pathways or your AV node. The QT interval, this is the time for the ventricles to undergo a single cycle. It could be lengthened by electrolyte disturbances, medications, conduction problems, coronary ischemia, or myocardial damage. And ECGs are valuable for detecting a lot of other problems, other arrhythmias, which are abnormal patterns of the cardiac electrical activity. And about 5% of healthy people do experience some abnormal heartbeats every day, so it's not unusual. Even if you've had too much caffeine or something else has happened physically or emotionally, it's not necessarily a clinical problem, as it says here, unless the pumping efficiency is reduced. You could have premature atrial contractions, though. They can occur in healthy people. The normal atrial rhythms can be interrupted momentarily by some surprise atrial contraction. You have stress, caffeine, as I mentioned, or certain drugs. They can increase the permeability of the SA pacemakers. But usually you'll have normal ventricular contractions that follow the atrial beat. Paroxysmal atrial tachycardia is a premature atrial contraction that triggers a flurry of atrial activity as seen in this ECG at the bottom. The ventricles keep pace, but the heart rate jumps to about 180 beats per minute. You can tell when this happens. In atrial fibrillation, the impulses move over the atrial surface at up to 500 beats per minute. And we have atrial quiver here. The problem is you don't have an organized contraction. And then the ventricular rate can't follow it, but it may remain fairly normal. The atria become non-functional, but the ventricles still feel passively. So you may not even realize there's an arrhythmia. There's also premature ventricular contractions, where you have the Purkinje cell of the ventricular myocardial cells depolarizing, triggering premature contractions. In this case, the cells that are responsible are called ectopic pacemakers. That's when you have a pacemaker other than the SA node. You can have single premature ventricular contractions that are common. They're not dangerous. The frequency is going to increase by epinephrine, stimulatory drugs, ionic changes, anything that's going to depolarize your cardiac muscle cells. And you see what one of those waves would look like at the bottom. Then there's ventricular tachycardia, or VTAC. That's when you have 4 or more PVCs without intervening normal beats, as you can see below. If you have multiple PVCs and VTAC, it could indicate serious cardiac problems. In ventricular fibrillation, also called VFib, this is responsible for a condition we call cardiac arrest. And I'm sure you've heard of cardiac arrest. It's rapidly fatal because the ventricles quiver and then they cannot pump the blood properly. For your pacemaker potential, the pacemaker cells in the SA and the AV nodes can't maintain a stable resting membrane potential. And then the membrane drifts towards threshold. So pacemaker potential is the gradual spontaneous depolarization. Usually pacemaker potential in the SA node is at 80 to 100 times per minute. So that establishes your heart rate. The SA node is going to bring the AV nodal cells to threshold before they reach that on their own, but the SA node paces the heart. You do have parasympathetic influences. If the parasympathetic division of your nervous system stimulates the heart, it's going to decrease your heart rate. So as you know, the parasympathetic usually does that lowering side of the nervous system. Acetylcholine from the parasympathetic neurons is going to open your potassium channels in the plasma membrane. That causes hyperpolarization of your membranes. It slows the rate of spontaneous depolarization. It also lengthens repolarization. So hyperpolarization means you get even more negative than normal. So that means it's hard to get a real action potential to occur. Now you also have sympathetic influence, which is the opposite. It stimulates increases in heart rate. So binding of norepinephrine to the beta-1 receptors is going to open ion channels. That increases rate of depolarization and decreases repolarization. Resting heart rates vary with age and your general health and your physical condition. The normal range is 60 to 100 beats per minute. The heart rate could be slower than normal. That's less than 60 beats per minute. That's called bradycardia. And if the heart rate is faster than normal, greater than 100 beats per minute, it's tachycardia. You also have cardiac centers of the medulla oblongata that can affect your heart rates. The cardioinhibitory center, they control the parasympathetic neurons that slow your heart rate. The parasympathetic supplies to the heart are via the vagus nerve. They synapse in the cardiac plexus, postganglionic fibers to the SA and AV nodes, and the atrial musculature in this case. And then the cardioacceleratory centers are also the medulla oblongata. They control the sympathetic neurons, and they increase heart rate. You have sympathetic innervation to the heart through the postganglionic fibers in the cardiac nerves. They innervate the nodes. They conduct, also the conducting system, the atrial and ventricular myocardium. So that's the cardioacceleratory centers. But both the inhibitory and acceleratory centers are both in the medulla oblongata. And this graphic shows those pathways. Stroke volume depends on the relationship between the end diastolic volume and the end systolic volume. Stroke volume can be compared to pumping water with a manual pump. I don't know if you've ever seen one of those. The amount pumped varies with the pump handle movement. Heart has two pumps, the ventricles that pump the same volume, and you can use a single pump as a model in this case. So as the pump handle raises, pressure in the cylinder decreases, water enters through a one-way valve. And it corresponds to passive filling during ventricular diastole. At the start of the pumping cycle, the water in the pump cylinder is equal to the blood in the ventricle. At the end of ventricular diastole, or the end diastolic volume. When the pump handle comes down, the water is forced out. That's your ventricular ejection. If the handle is fully depressed, the water remaining in the cylinder is the blood in the ventricles at the end of the systole, or what we call end systolic volume. So the amount of water pumped out is the stroke volume. And so stroke volume is equal to the end diastolic volume minus end systolic volume. Factors that affect your stroke volume, your end diastolic volume of venous return. That's the amount of venous blood returned to the right atrium. That's going to vary directly with your blood volume and any muscular activity and the rate of blood flow. Filling times and length of the ventricular diastole. So in this case, the longer that is, the more filling occurs, and so you have a higher end diastolic volume. Preload is the amount of the myocardial stretch. The greater the end diastolic volume causes a greater preload. The more stretching is going to cause stronger contractions and more blood being injected. That's called the Frank-Starling law of the heart. Okay, contractility is also an influence. That's the amount of force produced during the contraction of a given preload. It's increased by your sympathetic stimulation. Some hormones like epinephrine, norepinephrine, thyroid hormone, and glucagon will have an effect. But it's reduced by beta blockers and calcium channel blockers. Afterload, that's the ventricular tension required to open the semilunar valves and empty. So as the afterload increases, your stroke volume is going to decrease. The afterload increases whenever your blood flow is restricted, like when you have vasoconstriction, so when your blood vessels constrict and get smaller. Okay. So there's a lot of factors that affect cardiac output, and cardiac output is going to vary widely to meet whatever metabolic demands your body needs. The cardiac output can be changed by affecting the heart rate or your stroke volume. And heart failure is when you have a condition in which the heart can't meet the demands of the peripheral tissue. And just look over this particular chart and look at all the influences that you see on the cardiac output and how it affects other things. This shows on the left factors affecting heart rate and on the right factors affecting stroke volume. And just read over this and look at how these different factors work together to affect heart rate and stroke volume and overall the cardiac output.